Good evening, friends. Once again, I welcome you back in this interactive session on medicine. Friends, these sessions have been specially designed for the students who are supposed to appear in the practical examination. The results of the theory examination have been declared for some of those specialities, and for the specialities, they were declared very soon. The candidates will be given a 3 week period of time to appear in the final examination, practical. So, if you have got any sort of query regarding the practical examination, you can always ask us right now. You know our toll-free number, you know the fax number. You can fax us your queries or you can even call us. And Dr. Gupta, would you please like to tell us some practical tips in the practical examination?
Yes, Dr. Agrawal. What my advice to the students would be that they should be absolutely calm and quiet. No nervousness or anxiety should be on their part. That is true for every examinee, for every examination. The difference between national board examinations and this other postgraduate examinations in various medical institutes basically stays is that you don't have any internal examiner in this. But that sometimes is good also, because you have to do at your own level. My advice to the students is that whenever you are allotted a case, you should first know what is to be done with him or her. You have to first develop a rapport with the patient by asking name, his occupation, place of residence, you should be very courteous and very soft to the patient, and looking to his ailment, should start talking to him about his general complaints, chief complaints, and write them in chronological order. While asking present complaints and then family history, past history, personal history, it should touch almost all areas which are relevant to the patient's complaints, and you jot them down, brief important points. You may not write everything in vernacular. You may write in English brief points which you can describe when the examiner asks you. While you have taken history, you should make a provisional diagnosis in your mind. Say, for example, a patient comes to you with fever, cough, expectoration, pain chest, maybe frothy sputum which is blood tinged, and then you should know that the causes like this are probably pneumonia, lobar pneumonia, pulmonary infarction, or tuberculosis coming in acute phase. So there are so many other things which I am not going to talk at the moment as that, but you should know that these are some provisional diagnosis in the mind. Then you would examine a general physical system and try to corroborate your findings. You may ask certain leading questions in the history and then corroborate for the general physical examination. Then you examine the particular affected system. Say in this case which I was talking is a chest examination. After a good and a thorough chest examination, almost more than 75% you would know the diagnosis is clear. So for example, in this patient, if you are thinking the history goes in favor of lobar pneumonia, and on your examination also it fits into your lobar pneumonia, say on inspection, palpation, percussion, auscultation, you find that the patient has a bronchial breathing in a particular area of the crepitations, and it's likely that this lobar pneumonia in particular lobe. That will make your provisional diagnosis still closer to the final diagnosis, and then you are likely to ask for important relevant investigations and not unnecessarily expensive investigations, because many of the patients are not affording those many investigations. So once you write down your provisional diagnosis after examination, you should ask for investigation. Then you also list down investigations for the examiner's purpose. Say for example, in this patient you will only ask for a blood examination like peripheral blood film in total differential leukocytic count, and then sputum examination, maybe gram staining, maybe AFB staining, and then in chest x-ray, PA view. I think these things will almost make the diagnosis clear, and then the examiner may ask any other important investigation to differentiate from the present scenario. And then when you are talking about that, the examiner will certainly ask you, how do you manage this case? So then if you have made out a provisional diagnosis after investigations, you should be able to know that this is how you are going to manage. And in the management also, investigations plus the aims of management you should know. And aims of management would mean, say, in this particular case is that you need antibiotics, you need analgesics, you need pain relieving drugs, you need some expectorant, and you need some counseling, which is very important, which may be coming in the beginning or the end. But in any case, the patient's queries are to be answered. The patient will ask you, sir, how many days will I like to be in the bed? When my fever will be down? What is this pneumonia? How I am going to be cured? Because now the patients are demanding, and they are right also, because they have the right to know about their disease and the progress and the management part of the disease, not only because of expenses but because of their physical disability and burden to the society and to the relatives or the people. So what I mean to say is, the examiner is going to ask you what is your provisional diagnosis initially, then he starts with the history, then he starts with the part of the investigations, examinations, then investigations, and then he wants to know what is your provisional diagnosis, what are the probable differential diagnosis, then how will you differentiate, how will you prioritize your diagnosis line, and then how do you manage. And after management, one should know also the prognosis. Not only here we are stopping, the examiner may go into some of the important aspects of the particular ailment or some of the complications which the patient is likely to develop. Say for example, in this patient, if he has lobar pneumonia and on antibiotics he is not getting healed up, he may land up into ultimately lung abscess. So one should know what is lung abscess, then how is going to be treated, how is going to be investigated, how a bronchoscopy is done. So what I mean to say is, you should know little bit on this line also. Whenever you talk about a person or a patient, it is in totality. The examiner, given a long case, will like to ask right from the provisional diagnosis and how you have reached the diagnosis, and then management and prognosis, etc. That is what I would talk about, a case which is a long case given to you.
So many times in the examination, in the heat of the atmosphere, the candidate has a feeling to first know the diagnosis, and then he tries to build up the history according to that.
Yeah.
And sir, also the patient is carrying all his reports. So there is a feeling that you're first to see the reports, see all the investigation which have been carried out.
Yeah, I think it's a very good question, but one should refrain from such things. I, for one, see, I have in large practice over last 35 years in a teaching institution, always in a medical institute, PGI. I can talk out of my experience that I always till date first see the patient, talk to him, examine him, make my provisional diagnosis which is unbiased. Then I look to his plethora of investigations, or what are the treatment he has taken, what his relatives are talking about. Because if you see the investigations first, then you are biased. Probably you are dragged, your mind is thinking only on those lines, which may be erroneous, which may be wrong. The best guide to you for a good diagnosis is patient himself and talking to the patient at length and examining him.
So in the practical examination, is a student supposed to look at the investigations, and if the investigation report has been given to the students, it is, yeah. Good afternoon, friend. Please ask your question.
Hello.
Yeah. Hello.
Hello.
Yes. Please ask your question.
Hello.
Identify yourself.
I am Dr. Anirudh from Bokaro. I have got a question.
Mm-hmm.
When the examiner comes after the long case and asks us what is your case, then what would we say him? We will say the summary, or we start with the provisional diagnosis?
Normally, Dr. Anirudh, the examiner, if I am the examiner, my nature is to ask first the provisional diagnosis, which before we start. We get the student committed to a provisional diagnosis and any differential diagnosis before we go ahead with the history. But sometimes the examiner may ask you, all right, go ahead, my dear boy, and you continue with your history examination, then reach a provisional diagnosis. But before anything else is asked, any examiner would like to know the provisional diagnosis, differential diagnosis, how have you reached that particular diagnosis.
If you would like to, the candidates to ask any question if they have. This session can prove extremely beneficial for candidates who are appearing in the practical examination. So please do not hesitate to ask any question, any academic related question or any question related to the practical examination. Please do ask. Sir, also in the practical examination, sir, in the theory examination, so there is a feeling, sir, actually these are the list of recommendation which the examiners have given us.
Yes.
So they say, please draw the diagrams as and when required. So do you think the diagrams can be?
Yes, they are of help to an extent. Say, for example, a patient of mitral valve disease is there, and is a long question. Then what you write is hemodynamic changes. How will you show them in a diagrammatic manner, saying that these are the four chambers of the heart, and that is how the pressure builds up whenever there is mitral stenosis. How the left atrial pressure rises, then how the pulmonary capillary wedge pressure rises, then how the pulmonary arterial hypertension occurs. So this is how you can indicate or draw a diagrammatic type of thing. It's very important, not very important in all the cases, but in certain situations when some anatomy or physiology is to be shown, then you need it.
Also, my friends, there have been complaints that the handwriting of the candidate is not legible. I will give you a small example. In one of the in one of the answer sheets this year, the candidate was awarded 0 marks in all the 4 answer sheets just because his handwriting was not legible at all. He had just put some wavy markings, and what we could gather was the candidate knew nothing at all. And so just to confuse the examiner and the national board, he had made some wavy pictures and some ECG drawings, and his whole 4 answer sheets were filled up like that only. So please make sure you have got at least a legible handwriting. Then also the question number should be properly numbered. There have been cases when the candidate just failed to mention the question number in front of the answer. His question was not evaluated, and even if it was evaluated, it was not it could not be properly evaluated. Please draw a margin also. A margin should be drawn on both sides of the answer sheets, and you can always put up a question number on the left side of the answer on the margin on the left side. It actually gives a very good picture when examiner is checking the answer sheet. He is able to identify when a new question has been started and when the question is going to end. He will like to give the marks then and there only, and these marks are going to be copied on the jacket of the answer sheet. I mean, Jaipur. Yeah. Good afternoon, Jaipur.
Hello.
Yeah. Yes, doctor.
Hello.
Yes, doctor.
Yeah, I'm Dr. Vijay calling from Jaipur.
Yes, Dr. Vijay.
I want to, when we take history through an interpreter, it takes more time than other candidates taking direct history. So more time should be given for taking history when we are taking history through an interpreter.
See, normally, I mean, this is little disadvantage to the person who is not good at the local language or local dialects. But we all Indians most of the times know Hindi. So, or suppose there is a Rajasthani dialect sometimes. So, when there is Rajasthani dialect, one can understand. But if there is some difficult question or answer, it can be interpreted. Usually, the examiners are very, very accommodating. I, for one, would certainly say, all right, my dear boy, take 5 minutes more. There is no always line marked out 45 over. So you are always at liberty to get some more time. No problems, I don't think.
Yeah, this is a very, very genuine query from our candidates. See, actually, due to the paucity of the examination centers, we are forced to put some examination centers, practical examination centers in North India and a few in South India. So, in all probability, a candidate from North India will get a chance to appear in the practical examination in North India only, and a candidate from South India will appear in the South India only. But if unfortunately the number of practical examination centers are less, so the candidate will have to move to the other linguistic area, and that sometimes do create a problem. But anyway, these candidates are given some extra time, I believe, and even if they are not given extra time, they can ask for this time, and a genuine examiner will always oblige the candidate. Now see, there have been queries that the good afternoon,
Hello,
Jaipur.
I'm Dr. Jasmeet from Jaipur.
Yeah, good afternoon, Dr. Smith. Please ask your question.
Sir, I would like to know the last question which was asked by my colleague. Actually, the problem which we had was we were given a center in the south. We had an interpreter who was a ward boy, and after that the examiner asked us to interpret the speech disorder of the patient, which we couldn't understand.
Okay.
So that is a big problem. Means as such, a South Indian language is foreign to us,
Mhm.
and to interpret and give a speech disorder on that basis, it is just next to impossible for us.
I think your query is all right, but I would refer your query to the national board to give directions to the examination centers to take care. If it's a South Indian who is not well versed with the Hindi or North Indian languages, then probably he should or she should be given a good interpreter who knows good English, because he has to first interpret your language, then he has to take the Hindi and then translate back to you. Sometimes, but then there are such genuine difficulties. I'll request the national board to look into this matter.
Yeah, thank you, my friend. We have noted down this query and we will take care of this thing in future. So now we would like to continue with the examination of CNS. We have got with us Dr. Colonel R.N. Dhamija on my left. Welcome, sir.
Thank you.
And he is a formerly consultant physician and neurologist at Army Hospital, Delhi, Kent. See, CNS is one such area in which candidates feel that it is almost next to impossible. It's more like a mathematics, my friend. If you know the basics, if your basics are strong, if you are through with the fundamentals, you won't find any difficulty in examining a CNS case. Dr. Dhamija, I will request you to please give a candidate some insight into the examination of CNS case.
Certainly. I welcome you all for this neurological examination. The aim of the neurological examination is to determine the site and the nature of the disease of the nervous system. You see, this is a very important aspect which I am saying, the site and the nature. So, when we are examining a case, our aim should be that we must understand and try to evaluate where is the site and what is the nature of the illness the individual is suffering from. So, the clinical examination of the CNS should be thought of a technique for precise delineating the patient disability in the physiological and the anatomical terms. To know all these things, one must have a thorough knowledge of anatomy, physiology, autonomic nervous system, as well as the vascular supply of the brain. Unless you know all this, that what is the anatomy, what is the physiology, how the various system, autonomic or the other system are working, and what is the vascular supply, which artery is being involved, what is the vein which are involved, you cannot make a diagnosis unless one is aware about these things. And the various steps which are required for clinical examination of the central nervous system are the history. It is the paramount importance to know the history of a patient, and then is the neurological examination, that is the syndromic diagnosis. Then next is the anatomical diagnosis, pathological diagnosis, then one should try to make a etiological diagnosis and the functional diagnosis. So you understand that to have a good evaluation of a case of CNS, one must know the details of the history. So I am coming to the history again. It is very vital to spend time listening to the patient. Allow the patient to express uninterrupted. These days, what is happening is that most of the doctors do not have time. They are rushing. So they are hardly listening to the patient complaint. And if you have not listened to the patient complaint very well, you are not likely to make any type of diagnosis in this case. So to clarify this particular phrase the patient uses to describe his or her symptoms. The patient may say, I have a heaviness, on which may denote that possibly he has a weakness, or he is trying to mention us that it is because of the sensory symptom that he is having heaviness of the arm, limb or anything. Similarly, the headache. Supposing he is saying headache, go into the type of headache. What is the periodicity of the headache? What is the onset of the headache? Is it acute, chronic, regularly coming, or it is off and on coming? Any preceding factors which are important. Similarly, to give you another example, the patient may say, well, I went unconscious, which may explain, is it a vertigo, or it is a syncope, or it was a seizure. So anything out of them can occur in this type of situation. So unless one go into the details of the case, one is not likely to make a diagnosis in a particular case. After the patient finishes his or her illness of the account, it is very relevant question must be asked by the physician. That is the mode of onset. The mode of onset, I mean, is it acute onset, is it a chronic illness, or it is a abrupt illness? Because we know that the stroke, if it occurs abruptly, it is likely because of some embolic episodes, which may be from the cardiac source or from the any other source. If it is a subacute, it may be because of the subdural, that maybe patient may be suffering, or it may be slow growing tumor in a chronic patient. So the evolution of the patient is a very important in this case, and then one must go into the details of the illness in a particular case. The history showed, which is elicited from the patient, must be then put under the various headings like the chief complaints, then past history and the personal history, and the list of the medicines which the patient is taking. Most of the patients which are coming to the neurology clinic or admitted in neurological ward, they are, you see, basically a very chronic patient, and they may be taking lot of drugs. I give you example again, a patient who may be suffering from myopathy, it may be because of the corticosteroid induced. So drug history here is the most important. Supposing he doesn't give and he is suffering from COPD and he is having corticosteroids, whatever you may do, he is not likely to improve unless the corticosteroids are stopped. Similarly, a patient who is put on anti-tubercular treatment may be suffering from polyneuropathy. So you have got the patient says he has numbness in the feet, you examine him and you find that there are symptoms of polyneuropathy. But unless you go into details of the anti-tubercular treatment, one is not likely to hit a diagnosis and not correct the diagnosis, because you have to stop certain type of the drug in these cases. So the neurological examination, that as the patient narrates the history of his illness, one can observe if he is confused, whether is incoherence, whether he has a impairment of memory or the judgment, or he has a difficulty in comprehending or expression. So right from the patient you have interpreted, or he is giving the history, you can know a lot of things right from that point onward. Then a thorough general physical examination is very important in these cases. You may look for the cutaneous markers in the body, cephalot spots, there may be